Good morning, Your Excellencies, ladies and gentlemen. Welcome to the opening ceremony of the 29th TCTAP. This is an announcement, continuing on last year. Yes, I've been entrusted with leading the proceedings. Thank you very much for having me once again. First of all, we sincerely thank all scholars, doctors, and also personnel from the Department of Cardiology and all our attendees for offering us your time to attend our TCTAP 2024. I hope just that this meeting will give you the window of opportunity to share various knowledge on new surgical techniques and academics. And now, Your Excellencies, ladies and gentlemen, let us open our doors of today's TCTAP 2024 with an opening video clip we have prepared. Please pay your attention to the screen.
Journey within the bloodstream. Life bursts forth from your hands. Heartbeats. Breathe. Existence. You are the key to perpetual life. Hand in hand, we preserve the lives of many. Experience and share innovative thoughts. Interact with each other and draw your vision. Find a way forward here. TCTAP 2024 unfolds now. Your journey has already started with us. TCTAP 2024.
Why don't you give a big round of applause to open our doors of TCTAP 2024. Thank you. Thank you very much. Now, ladies and gentlemen, to kick off our meeting, it is my great honor to invite to the podium Dr. Seung-Jung Park, course director of this meeting, for his opening remarks on stage. Ladies and gentlemen, please welcome him with a big round of applause.
Thank you. Good morning. Welcome to the 29th annual meeting of TCTAP 2024. It is with great pleasure that we gather here today in the International City of Seungwoo, Incheon. As we marched into the 30th anniversary, TCTAP's brand new start in the new city symbolized growth and expansion. Last year, we brought together over 3,300 participants from the 81 countries, which represent the dynamic spirit of our community in the Asian Pacific region. And of course, this achievement was made possible by your continued support over the decade. This year's TCTAP will be showcase cutting-edge research, innovative techniques, and collaborative advancement with a remarkable global expert. Not only that, but you can also engage deeply by sharing the knowledge together, building lasting connection with your peers around the world. As we embark on this new chapter for next 2 days, let us inspire, create possibilities to shape the future of interventional cardiology. Thank you once again for joining us today and for being part of the TCTAP 2024. Thank you.
Thank you very much, Dr. Park, for organizing an event for cardiologists from around the world together to delve into their studies and share their insights. Thank you very much once again. And next, it is my great pleasure to invite to the podium Dr. Seungwoo Park, the president of the Korean Society of Cardiology, for his congratulatory remarks. Please welcome him.
Thank you. On behalf of the Korean Society of Cardiology, congratulations on great success of 29th scientific meeting of TCTAP. This year, we have more expectations as the meeting is held at the newer, more spacious, and more convenient venue, Seungdo Convention. As far as I know, TCTAP started as the Angioplasty Summit in 1995, initiated by Professor Seung-Jung Park, and has established itself today as one of the great, valuable practical clinical course representing the Asian Pacific zone in the field of cardiac intervention. To my information, this is up to date today morning. We have more than 3,000 participants from 54 countries on and offline this year. Through the meeting, I believe we can share the latest knowledge in many areas, and you will see very interesting live cases demonstration. I hope that this meeting will be a good opportunity for cardiology experts from various countries to exchange their opinions and strengthen friendships each other. Lastly, I would like to thank the founder of this course, Professor Seung-Jung Park, and other course directors, especially Professor Duk-Woo Park and the organizing committee for preparing such a wonderful meeting. Please enjoy the great meeting and the beautiful Seungdo in Incheon. Thank you very much.
A big thank you to Dr. Park for his support in making the TCTAP possible. Thank you very much once again. This year as well, we have prepared a variety of programs to satisfy our cardiologists and attendees. So we hope our event will grant you great insight for the value of time that you have offered. So let us take a look into what the TCTAP 2024 holds. Dr. Duk-Woo Park will give a brief overview of TCTAP 2024 program highlights. Please welcome him.
Thank you. So I'm going to briefly overview this year TCTAP 2024. So this year 2024 TCTAP, approximately 3,000 participants from 57 countries joined. It's 480 invited faculty, 300 lecturers, approximately 300 abstract cases prepared, 21 live cases from the 10 global live sites. Our TCTAP composed a 3-day, full-day session, as there are many, many interesting topics. Also, is a key component of the meeting is a live case demonstration. 13 sessions, 21 cases from 10 live centers in 6 countries, including China, Japan, Taiwan, USA, and Netherlands. So our program is yesterday was first day, is mainly focused on TCTAP workshop. We evaluated a lot of interesting topics, CTO PCI, left main PCI, TAVR, imaging and physiology, antithrombotic issue, and evolving PCI device. Today and tomorrow is the highlight day, and the day 2, we're gonna focus on the hot topic in the vulnerable plaque, imaging, and medtech innovation, interventional heart failure treatment, all about the data antithrombotics and coronary physiology and imaging. Tomorrow, we will evaluate all about tips and tricks in complex PCI, type of procedure, evolution of the valve intervention. Tomorrow is we gonna talking about the late-breaking clinical trial 2024 in the world, and all about new data from AMC, ongoing trial from ANC, and the best clinical trial from abstract. And the whole 3 days, and interesting, very informative abstract and case competition will be held. Our lifetime partner is Korean KCTA technician and nurse technology session will be held tomorrow. So thank you every global partnership session. We have is a very close international partnership session. It's a 10 international society, including TCT, CCT, and EBC, and Sing Live, and DocuValve, and the TTT, and the many important is the partnership. Also, in 3 days, we have a very expanded program and the satellite symposium in morning session and luncheon session, and the training center will be prepared, and we provided very important highlight on left-up interview. And the TCTAP award, this is a very memorable moment. And this year is 14 Master of Master, and also 11 Best Young Scientist Award. As many people remember the last year, that was absolutely memorable, the moment. Alan Crevier was last year recipient of the Master Award. So, and absolutely many people think about Alan Crevier, rest in peace. And who is the 14th Master of the Master Award, and after ending of this session, in this year recipient will be often. And the TCTAP 2024, we are very interactive relationship. The social media ambassador, we are real-time communicator about everything in TCTAP 2024. So here in Seungdo is a very beautiful city. Everyone, I hope, enjoy and discover in the new things, very good area in Seungdo, Incheon. Absolutely, I hope everyone enjoy Asian Pacific Educational Hub, TCTAP 2024. Lastly, remember, next year, 30 years anniversary TCTAP, we will back to the Seoul COEX. Thank you for your attention.
Thank you very much, Dr. Park, for the introduction of TCTAP 2024. We look forward to your participation in the wider range of conferences and activity events led by globally renowned researchers in each field of study. And do not miss to look around the beautiful city Seungdo as well. Now, ladies and gentlemen, we'll have the keynote lecture we are waiting for. First of all, it is my great honor to invite to the podium Dr. Gary Mintz. Ladies and gentlemen, please welcome him with a big round of applause.
Thank you. I've been asked to talk about vulnerable plaque diagnosis and treatment, and I'm going to put a little bit in the context of the recent publication of PREVENT. There are 5 questions that I think are important. The first one is, what are the best criteria and the best ways to diagnose vulnerable plaque? This meta-analysis showed that a large plaque burden, a small lumen area, TICVA by virtual histology, IVUS, or OCT, and large lipid core burden index predicted events at a patient level and as well as a lesion level. So it makes sense that the criteria for PREVENT included a lumen area less than 4, a plaque burden more than 70%, an LCBI more than 315, and TICVA by IVUS or by OCT. You can see that 70% of the lesions in PREVENT use virtual histology IVUS, which of course is gone, it's disappeared. So if we get rid of VH IVUS, The truth is that only NIRS IVUS predicted events and only out to 2 years, not at maximum follow-up. When we look quantitatively from data from Prospect 2 using spline and ROC analysis, you can see that the best MLA cutoff is less than 4.25, the best plaque burden is more than 70%, and the best lipid core burden index is more than 325, totally consistent with what was used in PREVENT. But in Prospect 2, it was the combination of a plaque burden more than 70% and an LCBI more than 325 that predicted events. Everything else was insignificant. You have to realize that there's disagreement amongst the qualitative technologies. So in this study, amongst patients with an LCBI more than 400, half had TICVAs and half had thick cap fibroatheromas. And so people are saying, well, AI is going to fix this for us. 6 studies have used AI and applied AI to OCT. 5 of those 6, ground truth were expert analysis. And if you look at 7 core laboratories deciding whether or not a lesion is a TICVA or not, the median kappa is only 0.22. The more unstable a lesion, the more there is disagreement amongst core laboratories, and we're not even talking about what happens in the cath lab. So I'd like to quickly introduce 2 technologies. This is from the US SpectraWave. It's deep OCT with co-registered NIRS. And you can see here, they really penetrate deeply, and this is near-infrared spectroscopy. And this is from China, a company called Panavision, where they use OCT in the near field, IVUS in the far field. These are hybrid co-registered images, and they create a hybrid image that uses OCT in the near field and IVUS in the far field. So I think we may have to look into new technologies to help us to answer the question. The second question I will ask is, what are the events and event rates associated with vulnerable plaques, and what events are prevented by treating vulnerable plaques with PCI? So again, from PREVENT, you can see that preventative PCI did better than optimal medical therapy alone. But if we look at the hard endpoints of cardiac death and target vessel MI, especially at 4 years, there was no difference between the 2 approaches. The differences were primarily the result of reduction in ischemia-driven target vessel revascularization or rehospitalization from unstable or progressive angina. And that is consistent with many previous registries that the hard endpoints are roughly about 1% per year. So I will ask you the question, does it make sense to do 803 PCIs to prevent 13 events at 4 years, of which 2 were cardiac deaths, 3 were target vessel MI, and the rest were ischemic-driven TVR or rehospitalization for unstable or progressive angina? And we can debate about that if you wish. In addition, the majority of TICVAs either heal, develop a thicker fibrous cap, remain stable, or rupture silently, leading to disease progression and a larger plaque burden rather than death, MI, and cardiac arrest. New TICVAs can develop, and therefore it's not surprising that in PREVENT, the advantage of preventative PCI was limited to the first 18 months. And so this summarizes data from 4 studies, 2 VH-IVUS, 2 OCT. They start off with 100 TICVAs, 60 heal, 40 persist, 53 new ones appear, and for a total of 92 at follow-up. And we're talking about follow-up at from 6 months to 1 year. Third question. What is optimal medical therapy, guideline directed or otherwise? And what percentage of patients in the OMT group in PREVENT actually took optimal medical therapy? So if we look at Prospect 1 and Prospect 2, over 10 years, where medical therapy clearly evolved as well as PCI evolved, there's a reduction in every single endpoint, hard endpoint or non-hard endpoint. And when planning PREVENT, The primary endpoint at 2 years were estimated to be 8.4% in the preventative PCI group and 12% in the medical therapy group, when in reality, it was 0.4% in the preventative PCI group and 3.4% in the medical therapy group, leading Carol Watson to say that this study also showed the benefits of guideline-directed medical therapy. The primary event rates in both arms were relatively low, which is a testament to remarkable efficiency of medical therapy. And I would like to point out that in PREVENT, less than 2% of patients were on a PCSK9 inhibitor, and high-dose or moderate-dose statins plus ezetimibe were used in only 60% of the optimal medical therapy group at 2 years or at 7 years. To show you some examples of what PCSK9s will do, this is a case from Japan, and you can see between baseline and 8-month follow-up, an increase in the lumen area, an increase in fibrous cap thickness, and a significant reduction in lipid-rich plaque. And amongst many studies, I just picked Pacman AMI, and you can see that high-dose statins plus PCSK9 compared to high-intensity statins had a greater reduction in atheroma volume, a greater decrease in maximal LCBI, and a greater increase in fibrous cap thickness. And this is a paper from Steve Nichols showing that the greater the reduction in LDL, the greater the increase in fibrous cap thickness at follow-up. Fourth question, what is optimal PCI in 2024? I picked this study that I published 2 years ago, not because it is anything special, but it happens to summarize all the meta-analyses over a 10-year period of time, showing that IVUS and OCT guidance improves outcomes when you implant a drug-eluting stent. So optimal PCI means imaging-guided PCI. And so we go back to PREVENT, you can see that when you're looking just at the BVS group, which is how the study started off, at long-term follow-up, there was no difference between preventative PCI and optimal medical therapy. And if we look at the everolimus-eluting stent group, you can see that the event rate at follow-up is remarkably low, 0.4% at 2 years and 1.3% at 7 years. And I don't quite understand, because Flavor, which had a similar enrollment population and optimized medical therapy, at 24 months, the event rate in the IVUS guided optimized group was 8.5%, pretty much what the PREVENT investigators predicted when they started the study. So I think we have to understand why the event rates in PREVENT were so unbelievably low, the lowest I've ever seen in the imaging-guided Xience implanted stent-treated group. And of course, we're now in an era where people are talking about using drug-coated balloons, which means we have to start this all over again, looking at drug-coated balloons versus optimal medical therapy. Last question, what clinical pathways make sense, and who should undergo imaging to assess and treat vulnerable plaques? In PREVENT, 5,600 patients were screened to identify 1,600 patients who met enrollment criteria. This is ridiculously inefficient. A better approach is to use CT screening, perhaps even just simple calcium scoring, to identify a high-risk patient population, and the presence of a 0 calcium score gives you a prescription that you're probably going to do well at follow-up, and those patients should never be enrolled in any of these trials. In addition, in Prospect LRP and Prospect 2, only half of the lesions that caused events were actually imaged by 3-vessel imaging. The other lesions were more distal or on side branches were hard to get into the vessel, which means that this is also inefficient starting off in the cath lab. So I would again suggest that we go back to the CT lab, because the CT lab can predict which lesions are most likely to cause events, and they should be targeted in the cath lab for imaging if you really want to do vulnerable plaque treatment. And lastly, of course, rupture plaques account for about 55%, plaque erosions for about 40%, and calcified nodules for 5% of the events. And I would like to thank and acknowledge Takashi Kubo, who has shared these 3 cases with me. This is baseline and 7 months follow-up of a lesion that developed plaque rupture. This is baseline and 8 months follow-up of a lesion that developed plaque erosion that had none of the enrollment criteria. And this is baseline and 9 months follow-up of a lesion that developed an eruptive calcified nodule that again had none of the criteria. So if I may conclude, I remain skeptical. That's me, I'm a skeptic. For many reasons, PREVENT has not changed my mind, and I've shown you some of them. My questions about the diagnosis and treatment of vulnerable plaque persist. However, it is time to reopen the discussion to plan the next chapter in vulnerable plaque diagnosis and treatment, especially large clinical trials, recognizing that this represents a continuously moving target, as happened with PREVENT. Thank you for your attention.
Thank you very much, Dr. Gary Mintz, to deliver us valuable information and knowledge and also precious experiences through the keynote lecture. Thank you very much once again. Now moving on to the next keynote lecture by Dr. Martin Bert Leung, but unfortunately he couldn't be able to be with us in person today, but he shared his time to prepare his video lecture. So ladies and gentlemen, let us watch the video clip.
It's a great honor that I have the opportunity to give a keynote address at this year's version of TCT Asia Pacific. The title of the lecture is The Next Chapter of Transcatheter Valve Intervention. Obviously, since we have little time, I'll need to be very selective about how I share with you at least my thoughts on where transcatheter intervention is going in valvular heart disease. These are my disclosures. So we're going to be talking largely about transcatheter trends and future directions. And I will focus on the new area of transcatheter tricuspid valve interventions because in the United States, this has resulted in a great deal of interest over the past several months. But starting with aortic valve disease, we have focused on the lifelong journey of patients with aortic stenosis. For more than 2 decades, we have really been obsessed with being able to perfect the index procedure, making it less complex, enhancing the technology, expanding the indications. But we also think as important at this stage is what we call the upstream events in aortic valve disease, including improved diagnosis, access to care, and especially preemptive treatment, and the downstream effects after the procedure, including valve durability, concomitant cardiovascular diseases, and adjunctive pharmacotherapy. We can't share all of these ideas, but let me at least share a few of them with you. The conceptual framework of upstream AS treatment recognizes that AS is a chronic disease and that earlier management coupled with meticulous follow-up would lead to better outcomes. So we believe that clinical research efforts should shift from late-stage reactive AVR to early-stage preemptive AVR and other complementary approaches. Of the upstream AS treatment using preemptive AVR in the asymptomatic severe AS patients, there have been 4 studies, 2 of which in surgery, recovery, and Avatar several years ago, and 2 involving largely transcatheter therapies, early TAVR and Evolve. There are also several studies in moderate AS, particularly the at-risk patients. First, the TAVR Unload trial, and then Progress and Expand TAVR 2, Progress being the largest trial that just completed enrollment. Importantly, of these trials, 3 of them will be presented with the final outcomes at TCT later this year, Early TAVR in Evolved and TAVR Unload. So we'll begin to get evidence and data in patients with preemptive AVR therapy later in 2024. We also believe that pharmacotherapy will become an important adjunctive therapy in patients with aortic stenosis, particularly during the course of AS development and even after AVR treatment. The medical therapy largely targets the ventricle to protect a pressure-overloaded heart while AS progresses and to augment LV recovery after AVR. And there are several classes of drugs that are being looked at, particularly the SGLT2 inhibitors. So when we think now about in the future how we'll manage aortic stenosis, and we divide it in this way, looking at the hemodynamic grade of severity of the valve lesion, as well as the staging of cardiac damage associated with AS, you can see that we only have a small number of situations where AVR has a class 1 recommendation. Many of the trials that I've just indicated will considerably improve our understanding of how to manage more categories of AS patients in the future. So to conclude, for aortic valve therapy, it will largely be transcatheter in the future. Some patients will have sole medical therapy, others may prefer to have surgery. But TAVR will be the dominant technology and the default therapy for most AS anatomic scenarios. There are still some evidence gaps that must be addressed and resolved. The conversation will shift to bioprosthetic valve durability and preferred therapy sequencing. The upstream or earlier use of TAVR in at-risk AS will become a common theme, including the development of valve remodeling and medical therapies. And our vision is that innovation will focus on artificial intelligence for screening and device phenotyping and novel, more durable valve leaflet technologies. Mitral valve disease is messy. The anatomy is complex. The device landscape involves many different categories of devices with overlapping solutions. If we just focus for a moment on the transcatheter mitral valve replacement devices, these are the first 10 devices that were introduced into clinical use, 7 of which no longer are being used. We hit truly a dead end due to incorrect clinical assumptions, technology roadblocks, and the inability to enroll or high screen failure rates in clinical trials. We now have second-generation TMVR devices, and as you can see, 8 of them shown here. Some examples: the Intrepid 29 French transfemoral system with larger valve sizes, as you can see here, or the Innovalve TMVR system focusing on secondary MR, which has gone through the early feasibility testing. We think we can redefine a path forward for TMVR therapy. The final goal will be transeptal TMVR delivery. We'll redefine the target population and anatomic requirements. Low-profile systems will be adaptable to anatomic variability with mechanical performance in real-world anatomy, including patients with MAC, and with more flexible clinical trials with increased collaboration. So our vision of mitral valve therapy is a little bit different. We think that there will be a majority of patients that will be offered transcatheter therapies, but still an important role for medical and surgical therapy. So mitral valve disease will require a toolbox approach comprising many therapies and will certainly continue to be challenging. There will be significant edge-to-edge repair growth for both primary and secondary MR in the future, but we need expanded clinical indications and new clinical studies which are ongoing. As we mentioned, TMVR has transitioned to low-profile transeptal access and should play an increasing role in secondary MR and MAC cases. The vision will be what we call a multi-device lesion-specific approach for initial therapy, perhaps followed by combination therapies for recurrence or device failures later on in the course. And finally, tricuspid disease. Certainly in our teaching during my academic lifespan, for the most part, TR has been considered an innocent bystander. I would say over the past 20 years, there is now a great deal of evidence under a variety of circumstances indicating that in severe and moderate TR, there is an impact on mortality in patients with heart failure, MR, AS, and AI. In fact, the most recent meta-analysis demonstrated from 70 studies that TR is associated with increased mortality independent of pulmonary pressures and right heart failure. So there's no question that TR is not an innocent bystander. Importantly, we've learned a lot about how to classify tricuspid regurgitation, and here you see in some seminal work that we now have several categories of TR, including atrial functional TR, ventricular functional TR, electrode-related TR, and primary TR. We've also learned to extend the grading scheme for patients with tricuspid regurgitation so that there is both severe, massive, and torrential TR. This was necessary because patients are underdiagnosed and they're undertreated, which results in very late presentation and the need for this extended grading scheme. There are 4 different categories of new transcatheter devices that have been tested in patients under various circumstances shown on this slide. How to choose which still remains a dilemma. But recently, 2 of these devices have obtained FDA approval: a tricuspid valve replacement technology, the Evoke system, and a tricuspid edge-to-edge repair system, the TriClip, based upon the Triluminate trial. Let's talk a little bit about these studies. The Triluminate study involving the TriClip edge-to-edge repair device was a randomized trial in 350 patients, 1-to-1 versus control, looking both at reduction in TR and a hierarchical composite endpoint, including hard outcomes and patient-reported outcomes, the KCCQ score. The TriScend 2 study was a tricuspid replacement therapy with the Evoke valve that came in 2 parts, using what's called a breakthrough device designation regulatory pathway. The first 150 patients looking at 6-month patient-reported outcomes, and then a total cohort of 400 patients of randomized patients, 2-to-1, looking at both patient-reported outcomes and hard clinical endpoints such as mortality, tricuspid valve reintervention, and annualized heart failure hospitalizations. Let's look at some of the safety and efficacy results. The Triluminate study with edge-to-edge repair was extremely safe at 30 days, with only adverse events occurring in 1.7% of patients. The replacement therapy had more adverse events, even though it did fulfill non-inferiority versus a performance goal, but the adverse events rates were higher. These would need to be balanced with greater clinical benefit. Looking at TR reduction, Triluminate edge-to-edge repair certainly reduced TR, but still 50% of patients had moderate TR at the end of the treatment. Looking at their primary endpoint, there were no differences in heart failure hospitalizations, death, or tricuspid valve surgery, but there was a large difference in patient-reported outcomes, KCCQ scores. Looking at TriScend, there was a greater reduction in tricuspid regurgitation, such that 95% had patients with reduced TR to less than moderate. There was also, at 6 months, using the hierarchical approach with patient-reported outcomes, a significant benefit in patients' symptoms. And at 12 months, importantly, there was also a significant trend benefit in hard clinical outcomes, including death, tricuspid valve intervention, and heart failure hospitalizations. So both of these devices importantly reduce TR. The safety profiles are acceptable, better with TR than TTVR. Neither therapy impacted hard clinical outcomes at 6 months, but the later trends with TTVR certainly favored improved clinical outcomes, and both increased patient-reported outcomes at 6 months and later, perhaps slightly more so with TTVR versus edge-to-edge repair. So I would conclude and provide a future vision for tricuspid therapy that the transcatheter approach will be dominant and that there will be an explosive growth as sole therapy and combined with mitral therapy, even potential upstream treatment. You'll see technology refinements in all categories. What's needed, however, is the preferred device for specific anatomies and clinical scenarios, improved imaging for diagnosis and therapy guidance, an understanding of major risk factors, improved clinical management strategies, and rigorous heart team training. We certainly think that these facilitated regulatory approval studies in the US are important, but we recognize that long-term follow-up is needed. There needs to be further reflection on the value of patient-reported versus hard clinical endpoints, and we need expanded clinical indications in future research projects. All of these themes are going to be dealt with in great detail at an upcoming meeting called New York Valves, which was formerly our transcatheter valve therapy meeting that will be in New York City on June 5th through 7th, where we're going to take a more global perspective on valvular heart disease, focusing on imaging, clinical management, surgical therapy, transcatheter therapy, and the importance of the heart team in managing these patients before, during, and after their index procedures. So I'd like to thank you for giving me the opportunity to share some of these ideas with you at TCT Asia Pacific this year.
Thank you very much, Dr. Martin Bert Leung, for the outstanding keynote lecture with the important information in this field. Yes, everyone, you are in the opening ceremony of TCTAP 2024, and we would like to take this gathering as an opportunity to have a special event. We have held the Masters of Masters Award to acknowledge those who have made remarkable contributions to the field of interventional cardiology and bestow the award to our outstanding experts. So, ladies and gentlemen, Dr. Seung-Jung Park, the course director of the meeting, will introduce the Master of Masters Award and announce the honorable name of nominee. Dr. Park, would you please?
Thank you. All right. This year's 14th Master of Masters. Okay, would you slide first? Okay, great. Welcome everyone to the 14th TCTAP Master of Masters Awards ceremony for 2024. It is truly a great privilege for me to present this award every year. Since 2011, the TCTAP Master of Masters Award was rewarded to acknowledge distinguished experts who have made remarkable contribution to the development in the field of interventional cardiology and to the growth of TCTAP. Here are our past 30 masters to whom I extended my heartiest appreciation for this expertise and dedication. And it is with last year's, Alan Cribier, a deep sorrow to acknowledge to passing of our 13th master, Alan Cribier. Although he is no longer with us, he will stay as a source of inspiration in our heart. Okay, thank you. And now let us find out the winner of the 14th TCTAP Master of Master Award, please.
Born on September 24, 1952, in Heerlen, the Netherlands, the master was a boy full of curiosity, wondering about the infinite possibilities while unraveling complex mathematical puzzles. The child grew up to excel in mathematics and physics at the Catholic University St. Radboud. It was during this time that he discovered his aspiration to address and alleviate the sufferings of others. Venturing abroad to collaborate on experimental research with distinguished experts in the United States, the master has begun to pioneer the expansion of the horizons in the field of cardiology. The master is currently the Director of Research at the Katharina Hospital, Eindhoven. The master continues to guide the future generations of interventional cardiology through his expertise and passion. Dr. Nico Pijls' remarkable contribution to the development of the FFR perfectly aligns with TCTAP's mission of enhancing treatment methodologies for heart disease patients around the globe.
Dear Nico, congratulations on winning the 14th TCTAP Master of Masters Award. When you first introduced the new concept of FFR, I believe this was a groundbreaking in the history of interventional cardiology. So, Nico, this is more than just an award, but it was a testimony to your historic milestone in your big heart. Congratulations once again for this brilliant accomplishment.
Among his notable achievements stands the conceptualization of the fractional flow reserve, a paradigm-shifting innovation that serves as a vital indicator in cardiology today. The FFR, which he invented in 1991, has enabled the minimization of unnecessary procedures by measuring the blood flow and facilitating precise diagnosis for planning streamlined treatment strategies.
Your impact on the field of interventional cardiology has been immense. Whether it's your early work with video densitometry, or the derivation and validation of fractional flow reserve, or your latest work with absolute coronary flow. But to me, your true legacy is the impact that you've had on so many trainees and colleagues. Your generosity, collaboration, and friendship are unsurpassed.
Throughout the extensive 30-year journey of FFR development, his long-standing partners have firmly supported him through collaborative efforts, with Dr. Bernard de Bruyne at its foundation.
Nico, I would like to take this opportunity on this award ceremony to thank you for this extraordinary and unique human and scientific adventure spanning almost 40 years. I'd like to insist on the fact that it is you who deserves the credit for crystallizing the concept of fractional flow reserve and theorizing its validity. Our magic recipe has been to collaborate openly and synergistically since day one. Nico, I hope you will have the chance to celebrate this award with the many colleagues and friends who have joined us and have accompanied us on the journey of coronary physiology, many of whom are probably present at TCTAP.
I'd just like to contribute to that since I've known him a long time and view his work as the major translation from the basic experimental fluid dynamic equations into the clinical realm of applied clinical coronary pathophysiology that's moved beyond the angiogram. So it's a major milestone. I'm deeply indebted to Nico. I'm greatly honored and have great fond memories of him coming to Texas to work out the equations that are the basis of his fantastic advance.
You, a cardiologist and also a biomedical engineer, invented fractional flow reserve by linking hemodynamics with coronary physiology through an analysis involving some 40 mathematical equations. Equally impressive, you managed to get that theory along with its detailed validation published into circulation in 1993, and I am proud to have worked with you on that foundational paper. Indeed, you are a cardiology master, but you're also a damn good engineer. Congratulations.
Dear Nico, as a friend and colleague for more than 30 years, it's a great pleasure and honor to congratulate you with your truly deserved title Master of Masters. We've been working closely together and we were both satisfied with this cooperation for more than 30 years. I really hope to work with you together in the future, and I wish you all the best.
As such, Dr. Nico Pijls is acknowledged as an inspiring mentor and a good friend to many of his colleagues.
You often mention that the most valuable part of your career are the more than 20 PhD fellows that you've guided as a professor at the Technical University here in Eindhoven. I was one of them, 2 significant careers, but you've also molded these persons and made them better people in their daily life. I truly believe that, and this is all recognized because of you.
I think you are someone who really made a difference in our
cardiological interventional field. And I'm very pleased to call you, I think, a dear colleague and a friend for many, many years. Even though you are so-called retired, you still take a deep interest in the science that you also shaped. But what I'm envying most is that you look the same today as when we met maybe 25 or 30 years ago. Well, I changed a lot and lost a lot of hair, but you never lost your enthusiasm.
I think your exceptional work on fractional flow reserve and microvascular resistance reserve has touched the life of many, many patients around the world, and I think myself and the overall community is grateful for that. Thank you again. Enjoy and celebrate, and I hope to be there next to you.
On a personal note, I've been very lucky to be invited by Nico to spend a year in the Netherlands. He was extremely gracious in inviting me and my family to come and spend a year in Eindhoven, where I worked alongside him in the cath lab. We did research projects together, and we helped mentor fellows, and also I received a lot of great personal advice and support from Nico in my own career, something that I think he has been really selflessly able to give to 20, 30 PhD fellows during the course of his career, as he has helped develop the next generation of researchers. Nico, congratulations.
Dr. Nico Pijls stands out as a visionary interventional cardiologist who has pushed the boundaries of innovations within the field. Indeed, the cornerstone of his motivation stemmed from the unwavering support from his loving family. The blend of his personal virtues and professional accomplishments remains a perpetual wellspring of inspiration for us, ensuring his legacy as a true hero of our time and for many generations to come.
Ladies and gentlemen, 14th Master of Masters goes to Dr. Nico Pijls. Please welcome him with a heated round of applause and roaring cheer. Congratulations! The Dr. Park will present you with plaque. Congratulations, your dedication is what enabled the heart beat strong once again. Congratulations! We need another big round of applause to celebrate this moment. And also, we can't miss to take a commemorative photograph. We'll take a photo. Congratulations! Thank you very much. And also Dr. Nico would like to share with us your feelings, and also I know you have prepared your presentation, please.
Dr. Park, organizers of TCTAP 24, ladies and gentlemen, it is a great honor to receive this award. And I also believe it is a great honor to give this lecture to you about 50 years of coronary physiology. Of course, in 20 minutes, I cannot mention everybody who contributed to this, but I will try to make a selection. These are my disclosures. In the 60s, awareness arose among scientists that coronary blood flow was regulated by a sophisticated physiological system and was held constant in resting conditions despite changes in perfusion pressure. And similarly, it was observed that blood flow could increase in response to increased demand. And it was suggested that such autoregulation could also play a role to maintain resting blood flow normal in case of a coronary artery stenosis. These assumptions were made experimentally validated and synthesized into a coherent theory by the seminal work of Lance Gould in 1974, who introduced the concept of coronary flow reserve and paved the way for applied coronary physiology in the human cath lab. This is Lance Gould. And I will first spend a few words to autoregulation. In a normal coronary artery, in the epicardial vessel, is almost no resistance. Resistance is made in the arterioles and the microcirculation. And it is large in resting conditions and then it can decrease by a factor 5, thereby enabling blood flow to increase by a factor 5. However, if a stenosis occurs in the epicardial vessel, this is an additional resistance to flow. And as a response, the distal resistance will exactly decrease by the same amount as has been added to the proximal vessel. Therefore, the reserve is decreased, let's say to 3 in this case. And if the stenosis becomes very severe, the distal resistance can be consumed completely, and that means that no further dilatation is necessary anymore, and we are on the edge of unstable angina pectoris. This was validated experimentally in dogs by Lance Gould, who measured resting and hyperemic blood flow with an increasing stenosis. And he showed in these animals that resting flow remains constant up to subtotal lesions, but that maximum flow already starts to decrease much earlier. And the difference between the ratio, I should say, between maximum flow and resting flow was called coronary flow reserve. At that time, the only way to create coronary hyperemia was an occlusion of 20 seconds. You see that here in a dog, and you see that maximum flow equals approximately 5 times resting blood flow. Then it became 1976. In the late 70s, the world changed by the unsurpassed courage of Grünzig, who opened the gate for applied coronary physiology in conscious humans. Grünzig was greatly interested in coronary pressure and tried to measure coronary pressure by his balloon catheter routinely. Andreas Grünzig in 1979 cited, "I wished I could measure hyperemic pressure, but a resting gradient is all I have now." And next, with the introduction of monorail balloon systems, the interest in direct coronary pressure measurement faded away for more than 10 years. And by the introduction of QCA in the 80s, cardiologists hoped that the mismatch between angiography and physiology would disappear. But nothing was less true. The mismatch between anatomy and physiology was not improved at all by QCA, and it became more and more clear that not the morphology of the lesion is decisive for having angina, but a decrease of maximum blood flow. And coronary autoregulation in the humans remained a virtual concept for the time being. In the late 80s, Bob Wilson and Melvin Marcus in Iowa discovered a number of reliable hyperemic stimuli to be used in humans. This is an example of papaverine, and you'll see the same hyperemic response as after 20 seconds of occlusion. And then in 1990, Morton Kuhn for the first time measured intercoronary blood flow velocity directly by a Doppler guide wire compatible with contemporary PCI equipment. And he investigated coronary flow velocity reserve in humans as a measure of functional stenosis severity. By the work of Kuhn and others, the knowledge about coronary physiology, its influence on stenosis and improvement after PCI rapidly increased. And a Doppler wire became the standard tool for a while for physiology in the cath lab by measuring CFVR. However, in the next years it was realized that CFR can vary considerably within one patient due to hemodynamic changes, that CFR is not a specific index for the epicardial stenosis, but is also influenced by the microcirculation, and that CFR by Doppler is often difficult to obtain. In at least 30% of the patients, no really reliable measurements can be done. And a necessity was felt to have an index which is specific for the epicardial disease and easy to measure in almost all patients. And that is FFR. FFR was introduced in 1993 by Bernard de Bruyne and myself. And the basic principles are that in the first place, it is not resting blood flow, but maximum achievable blood flow, which determines the functional capacity of a patient, and that at maximum vasodilation, blood flow to the myocardium is linearly proportional to myocardial perfusion pressure. And consequently, FFR is defined as maximum achievable blood flow in the presence of a coronary stenosis as a ratio to normal maximum flow. That is easily understandable from this slide. In the upper part, you see a normal coronary artery and the microvascular bed. The perfusion pressure at hyperemia is supposed to be 100 millimeter mercury. In the lower part, there is a stenosis in the epicardial artery and a gradient. But it is not that gradient that matters. It is the fact that due to the stenosis, the distal perfusion pressure has decreased to 70, whereas it should be 100 under normal conditions. And that means that also maximum blood flow in the lower situation has decreased to 70% of what it should be in the upper situation, the normal situation. And that's exactly what FFR is, the fraction of maximum blood flow, which is maintained despite the presence of the stenosis. There were some major limitations in the first years. Few people believed it, and there were no commercial pressure wires available to check, to experiment with the theory. So the first studies was done with homemade devices. What I did was stripping the balloon from a 2.8 over the wire old-fashioned balloon catheter, and I glued that by Bison kit to the last 20 centimeters of a hollow guide wire, 0.014. And with that wire, only the wire part in the coronary artery, we could measure reliably phasic coronary pressures, as you see in this tracing from one of our first docs. And we validated FFR in the element experiments very nicely. Here you see on the vertical axis, the FFR as derived from the pressure measurements, and on the horizontal axis, the FFR as truly measured by volumetric blood flow. And you see a very nice one-to-one relation, and this was also validated during changes in blood pressure, heart rate, and contractility. Soon, commercial 0.014 sensor-tipped guide wires came on the market, pioneered by Radi Medical Systems in Uppsala and Sweden. Over the years, these wires have been greatly improved and can be used now as a primary PCI wire in almost all patients. All aspects of FFR have been extensively validated in hundreds of studies, and FFR is applicable in almost all clinical and angiographic conditions. And FFR is considered now as the gold standard for decision-making with respect to the presence of inducible ischemia and the need for revascularization with important consequences for outcome. This is just one slide, the most impressive slide I've ever seen in the field of PCI. It is the FAME2 study, 1,220 patients with an average of 2.7 lesions, multi-vessel disease. In all these lesions, FFR was measured. And if FFR was negative in all lesions, so there is no ischemia, you have the green line. And these patients have a quite favorable outcome. If, however, ischemia was present by at least one of the lesions, then the patients were randomized to be treated medically, the red group, or by PCI, the blue group. In the first place, you see that the red group does much, much worse. Remind that the red and the green group are not different in the field of angiography. The only difference is that the green group has no positive FFR and the red group has. So you see that there is a quite difference in outcome between non-ischemic and ischemic lesions if you follow the natural course. And then the most important, if the patients with at least one positive FFR had PCI, you get the blue group, and you see that there is a large benefit of PCI, and even PCI brings back the risk to normal, to the ones who have no ischemia at all. This is really impressive and very encouraging for PCI and chronic stable angina. Now I make a small sidestep to imaging. And you see here Paul Yog and Gary Mintz. And there are many more people who contributed to this work, but these two persons were seminal. They invented IVUS and OCT, and although strictly spoken, these are anatomic imaging methods, these techniques also taught us a lot about structure and evolution of plaques, and enhanced our insight what PCI does. And recently, we have seen the PREVENT study 2 weeks ago in the Lancet, which is a milestone by demonstrating that discrimination of vulnerable plaques makes sense and that PCI of such plaques influences outcome. Now we make a jump to the coronary microcirculation. In the last 20 years, awareness arose that in particular in women, angina and coronary ischemia are not the exclusive domain of the epicardial arteries, but that also disease in the coronary microcirculation may play a role. And presently it is believed that that may be the case in at least 25 of the patients. Microcirculatory disease can be structural or functional, and the question is how to assess it. CFR is decreased both with epicardial and microvascular disease, so it is non-specific. And FFR is specific for epicardial disease, but gives no information about the microcirculation. So the search was for more specific indices of the microcirculation. And the first was the principle of bolus thermal dilution, which was invented also by Bernard and me between 1999 and 2001. And it was Bill Fearon who synthesized this into a useful index called IMR. The principle is simple. A bolus of 3 millimeters of saline is injected through the guiding catheter, and its temperature is measured in the distal artery. And then the time is measured, which is needed for the bolus of cold saline to travel to the distal artery. That time, mean transit time, is inversely proportional to flow. And because resistance equals distal pressure divided by flow, at hyperemia, the product of distal pressure and TMN is a measure for the resistance of the microvasculature. That is called IMR. This is an example. Look at the orange lines. IMR is measured 3 times, and the IMR is simply found by the product of the distal pressure and the mean transit time. It is 24 points in this case. The index of microvascular resistance is rather specific for the microcirculation, but needs correction at higher degree of stenosis. It has been shown to have prognostic significance, both in stable angina and post-STEMI, and it was the best we had during 20 years. But its reproducibility is far from optimal. It is not always easy to determine. Sometimes you need to repeat injections many times, and there is no direct measurement of microvascular resistance. So that brought us to the volumetric measurement of absolute blood volume resistance and microvascular resistance reserve. Before I go into that part, first I make a side jump to IFR, introduced by Justin Davis. Because FFR needs an hyperemic stimulus, attempts have been made to make such measurements easier by trying to avoid the necessity of adenosine. And it was claimed in 2011 that during a so-called wave-free period, resting distal to proximal ratio, called IFR, would be equal to FFR over the complete heart cycle and could replace FFR. The physiologic basis for such a wave-free period was lacking, and there were 2 large, almost identical trials to demonstrate the non-inferiority of IFR compared to FFR. And these trials, however, when you read the papers carefully, only low-risk patients were included, and false negative IFR was actually excluded by design. This bias was not recognized by the investigators, nor by the New England Journal of Medicine, nor by some guideline committees. And in those study populations, non-inferiority of IFR at 1 year was demonstrated, whereafter, without additional RCTs, the results were extrapolated to all patients, including patients with complex anatomy. However, at 2 and at 5 years, the mortality was significantly increased when using IFR, and subsequently, both in JECC and the European Heart Journal, it was actually recommended to abandon the use of IFR for decision-making. This is the mortality in the defined flare study here on the left hand, and you see that the mortality at 2 years with IFR in this low-risk population is very high, 4%. It is twice as high as the mortality with FFR, and it is exactly as high as the mortality in the angio group of the FAME study, which were much more complex patients. So the conclusion from these major journals were to be cautious with IFR and to use FFR as a gold standard. Now we go back to the microcirculation again. Can the black box be opened? I will discuss that in more detail later today. Between 2016 and 2021, Bernard and me developed a methodology to measure absolute blood flow by continuous thermal dilution and derive an index called microvascular resistance reserve. The principle is quite simple. Suppose you are interested in the blood flow and the total resistance of the anterior wall. Then you put the pressure temperature wire in the distal coronary artery and the specific infusion catheter in the proximal coronary artery. This infusion catheter has a number of side holes and ensures that when saline at a rate of 10 or 20 milliliters per minute is infused, complete mixing will occur immediately. And suppose now that the saline is entering the coronary artery at a temperature of 3 degrees below blood temperature at a rate of 10 milliliters per minute. And that after complete mixing, the temperature equals 0.5 degree below blood temperature. This is a factor 6, so the blood flow must be then 6 times the infusion flow, 60 milliliters per minute. This is an example at hyperemia, 20 milliliters per minute. You recognize the screen with the red and the green signal being the pressures. Here you have the situation before we start infusion. Then we start the saline at 20 milliliters per minute, and you see that hyperemia develops immediately and that FFR is 0.77. Very rapidly, a steady state temperature in the distal coronary artery is achieved. The temperature there is minus 0.34. Then, at this point, the sensor is pulled back rapidly to the tip of the infusion catheter, measuring the infusion temperature, which is minus 4 degrees below blood temperature. And here the saline infusion is stopped. Everything goes back to normal. And you can very easily calculate then that the maximum coronary blood flow is 252 milliliters per minute, and the minimum microvascular resistance is 325 units, which is completely normal for an anterior wall. So absolute coronary blood flow and microvascular resistance reserve enable to measure Q-resident RMU at rest and at hyperemia. No hyperemic drug is needed because 20 milliliters per minute of saline in itself creates maximum hyperemia. FFR is automatically measured at the same time, and therefore also the normal reference values for Q and R are known. For the first time in history, invasive measurement of absolute coronary flow reserve is possible. You get it for free. And finally, also microvascular resistance reserve can be calculated, which is the most accurate, reproducible, and super-specific index of the coronary microcirculation. MMR is not affected by mass or epicardial disease and completely operator independent. It is given by this equation, which combines, as I believe, the three major indexes of the coronary circulation. That's why I called it the unifying equation of coronary physiology. I will give a lecture about this also later today. Now we go back to Gould, to the dog experiments, and we repeat them now 50 years later in a human. This is a gentleman who just had a stent in a proximal LAD stenosis. And after stenting, we put a balloon into the stent and slowly inflated that balloon, creating an increasing stenosis. And at the same time, we measured continuously resting blood flow and then hyperemic blood flow. And when you do that, you see with the increasing stenosis that resting blood flow remains completely constant up to a very tight lesion. And the hyperemic blood flow very nicely decreases. In Gould's picture, this was a curvilinear situation. We have a linear line because Gould expressed the stenosis as a percentage of diameter, and we express it as fractional flow reserve. Of course, we didn't go to the very right end because that was felt not acceptable from the ethical point of view. So this is exactly what Gould did, but 50 years later in conscious humans in the cath lab, and you can do it in a few minutes. Coming to the conclusions from this magnificent journey, ladies and gentlemen, interventional cardiology is a dynamic and rapidly evolving world, facilitated by the great meetings, which are unique for our field, spreading out the knowledge rapidly. These meetings are founded by great persons. You see them here, but many other authors should also be mentioned. After the first angiograms by Soames, need for a better physiological understanding of the coronary circulation arose quickly. Between 1977, Andreas Grünzig, and today, we not only learned sophisticated interventional techniques, but also learned how and when to apply these based upon sound physiological principles. In 50 years, we came from the experimental dogs of Gould to a complete understanding of coronary pathophysiology and its routine application in the human cath lab. And presently, FFR, CFR, absolute flow and resistance, and MMR provide a complete and accurate description of both epicardial and microvascular disease. Thank you for your attention.
Thank you very much, Dr. Nico, to give us the opportunity to look into the history of the development of interventional cardiology. Thank you very much. We'd like to invite your sets back. Thank you. And also, congratulations once again. We hope you will be with us every step of the way on advancing mankind's interventional cardiology. Now, ladies and gentlemen, unfortunately, it is time to wrap up all the programs of the opening ceremony and Master's ceremony. But we have abundance of interactive and exciting sessions remaining until tomorrow. So please give your attention to the very end of all programs of TCTAP 2024. And also please enjoy the meetings and warm and beautiful weather here in Korea. Thank you very much. 감사합니다.